Hello, it's Dr. Storms. I'd like to talk about a clinical conundrum, something we see in our patients. And question, why does it happen? Why does my biologic patient feel better when the FEV1 hasn't improved? So we'll talk about the difference between spirometry and clinical outcomes with biologic therapy. So first, talk about the patient over on the left. Severe persistent asthma. She's on ICS LABA/LAMA. She's compliant. She's got normal chest x-ray, sinus CT, no GERD. So she has no other complicating aggravating factors. She started biologic treatment. After treatment, she exercises much better, less breathless, fewer rescue inhalers, but her FEV1's unchanged. So why is that? That's what I'm going to talk about. Spirometry is unchanged, FEV1 still is low. How can the patient feel so much better when their FEV1 hasn't changed? So it's really not a paradox. It tells us what the FEV1 shows and what it misses. FEV1 shows large airway obstruction, bronchoconstriction, fixed mechanical airflow limitation. So it's a single forced breath snapshot of large airway mechanics. It misses mucosal inflammation, mucus hypersecretion, small airway disease, bronchial hyperactivity, dynamic hyperinflation, and symptoms and quality of life. So the key point, FEV1 measures airflow obstruction, not inflammation, not symptoms, not quality of life. 5 reasons why this patient would feel better on the biologic, even though the FEV1 hasn't changed. First, reduce airway inflammation. The biologics suppress type 2 inflammation, eosinophils, edema, mucus. 2, there's less dynamic hyperinflation, which directly explains the improved exercise tolerance. 3, small airway disease improves. The FEV1 is not sensitive for small airway disease. It's insensitive. FEF 2575 may help you in that area, but the patient has to blow 6 seconds. They have to have a good curve, etc. So biologics reduce inflammation throughout the airway tree, including small airways. Number 4, fewer and milder exacerbations. Number 5, the fixed remodeling is still there because the low FEV1 shows that irreversible remodeling, fibrosis, smooth muscle hypertrophy, whereas the biologic treats the active inflammation, not the permanent architectural problem. So here on the left we have core concept number 1, structural remodeling, and on the right, active inflammation. So the fixed mechanical obstruction includes subepithelial fibrosis, smooth muscle hypertrophy, airway thickening, goblet cells, vascular remodeling, and biologics cannot reverse that. Inhaled steroids don't reverse it. The active inflammation on the right is what biologics treat. Eosinophils, mucosal edema, hypersecretion, mast cell activation, bronchial hyperreactivity. So the result is that dynamic, reversible symptoms that biologics can suppress will improve. Whereas on the left, the fixed mechanical obstruction that shows in the FEV1 cannot be improved with biologics. There's data from the major trials, MEPO, DENMRA, DUPI, and OMA. Exacerbation rates improve significantly in all these trials. Symptom scores improve significantly. But look at the FEV1. Modest changes, 100 cc's, 100 cc's. So down at the bottom, across all these trials, symptom scores and exacerbations improve even when the FEV1 changes are modest. This is expected, not a treatment failure. So when the patient comes back, you show them their FEV1, and they say, oh, I'm not any better. Say, yes, you are, because the biologic treated something else. Your symptoms are better, your quality of life is better, etc. So, next slide. The take-home message, FEV1 and symptoms differ. Patient can have significant improvement in symptoms with the same FEV1. So we have to kind of change our thinking about FEV1. It's not the cure-all thing that we look at. The low FEV1 can reflect irreversible remodeling because of years of inflammation. Biologics target the active inflammation that's going on, not the fixed obstruction. As I mentioned, they suppress type 2 pathways. So your patient is responding to her biologic based on improved symptoms, exercise capacity, fewer exacerbations. So we have to look at those things rather than the FEV1 when we put a patient on biologic to try to determine improvement. If you're just going by the FEV1, you're going to say, well, the patient's FEV1 hasn't changed, the biologic didn't work. That's not true. Number 5, use validated outcomes, ACQ, ACT, exacerbation rate, etc. And ask the patient, is there something different they do now that they couldn't do before the biologic? How much did they walk before? Could they walk upstairs carrying groceries? Could they bowl? Could they do this? Could they do that? Because people don't remember. So don't give up on the biologics. Here's a few references if you want to look at those. So this is the end of this clinical conundrum.